we had an organization come to us and they said, we want to buy your accreditation. And I said, well, you can't buy our accreditation. You can apply for our accreditation. And they said, well, tell us about your standards. I said, things like, are your people credentialed? Are you following HIPAA? And they said, what's HIPAA? I said, let me save you some money. Don't apply for our accreditation. If you don't know what HIPAA is, you shouldn't be doing telehealth. And so our telehealth, we had this surge of organizations who came in who earned our telehealth accreditation, good quality organizations. And we were actually approached by somebody from the Middle East. And they said, when we look around at places around the world who are doing telehealth accreditation, your program stands out. Would you consider accrediting us? And it was an organization, Ann Shams University in Cairo, Egypt, that was setting up telestroke coverage. And they said, we wanted to follow your best practices. So we were not doing international telehealth before the pandemic until we were approached by organizations who said, we want to do your standards. And they were our first international accreditation.
They approach you, they get the accreditation that helps them in other countries.
It helps them in other countries.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right, welcome to the latest edition of Analyzing Healthcare, the Scale Community podcast. I'm joined by Shawn Griffin, the CEO of URAC. Am I saying it correctly? Is it you?
It's URAC. I always say it's interesting. If somebody knows us, they pronounce it right. If somebody doesn't know us, they pronounce it in all sorts of different ways. I've been called URAC. I always say, like, this is my rack, that's URAC. So it's an easy way to pronounce it.
For anyone who doesn't know URAC, the primary letter is the A. It's the accreditation.
Yes.
So, I'm familiar with accreditation groups. Who do you compare yourself to? Joint Commission? Who else is out there that you think about?
If you want to talk about accreditors, large healthcare accreditors, the Joint Commission in the hospital space, NCQA is in the health plan space with us. You've got AAAHC, which does their area, CARF. You've got all sorts of specific areas. We're probably the broadest. We do everything. We have over 40 different accreditation programs, and we believe that helps to bring sort of consistency up and down the chain when it comes to healthcare. And I typically say we accredit everything but hospitals. So we don't compete with the Joint Commission on hospitals per se, but we actually accredit, I think it's like 15 of the top 20 hospitals for something within their space. So I'm signing certificates for organizations, everything from a mom and pop pharmacy out in rural Iowa to an academic medical center in Boston. So it's really a broad arena that we play in.
And pretty stable. I've been hearing about URAC for the 15 years that I've been in healthcare. Joint Commission. It's the same 3-4 AAAHC, it's the same 3 or 4 accreditation groups that everyone turns to. And that's not a surprise. The whole point of accreditation is that the brand is known. And so you're taking some risk out of the equation, right? You're taking if it's a provider group or a health plan that is otherwise unknown, you're giving them credibility by literally them taking your stamp of approval and adding it to their website, adding it to their materials.
Yeah, we've been around for over 35 years. Our name betrays the fact that we start out with utilization review. That's where the UR comes from in URAC. So back in the 90s when it was the HMO days and everybody was concerned about utilization review, a bunch of groups got together and said, we need some rules for the road. And we were created back then. So my board is everything from the American Medical Association, the American Nurses Association, AHIP, the health insurers, Blue Cross Blue Shield, the employer groups, National Alliance of Healthcare Purchasing Coalitions. So we have a multi-stakeholder gathering, and I always say that we have all the voices around the table, but nobody gets a veto. So it's really about what's best for patients, and that's what we've been doing for 35 years. So we have government-deemed programs in multiple areas for the health plans on the marketplace. You have to be accredited. We have a lot of specialty pharmacy programs that are recognized in those things, credentialing. The No Surprises Act, when that was passed, they actually recommended a URAC accreditation for the independent review organizations. So we're pretty well recognized. We're sitting here in Washington, D.C. on an icy, snowy, sort of cold day, but we affect everybody across the country and actually a few around the world. Our telehealth accreditation, we telehealth accredit in Africa, in South America, in the Middle East. So a lot of things.
I'm going to come back to a few of those points because they're all
Okay.
fascinating. I'm actually going to interview the former president of the American Nurse Association, Beverly,
Okay.
over the next few weeks. I'm looking forward to that. It's an important voice in healthcare that I don't think gets enough attention. So I'm looking forward to it.
Yeah, they're a great group. They're very involved. I'm actually speaking with them later today about our AI accreditation. So we have a lot of common interests and things that we work together on.
Yeah, I want to come back to AI as well. So, first question, what is that board, esteemed board, many different voices, what do they talk about? What do they decide with you? I imagine you're not necessarily going through P&L cash flow statements. I'm thinking you're probably spending more time on refining and updating your different accreditation programs and the impact that has downstream.
Yes,
Am I
actually,
getting warm?
yeah, our bylaws require that our board approve every program that we issue. And so what they will do is they will come together, and there's actually multiple levels of involvement. Some of them have named board seats. We also have some at-large board seats. But what they do is they will help us when it comes to bringing together stakeholders to create a program from scratch. So like our AI accreditation, we put out an open call for organizations that were interested in contributing to our AI accreditation, and those organizations can nominate people. Also, they serve on some of our advisory committees. We have a health standards committee, a pharmacy advisory committee, those sorts of things. And so, they contribute to the creation of our programs. They then approve our standards on a regular basis. Years and years ago, decades ago, they used to contribute to the funding of our operations, but we haven't needed that for a couple decades. And so they guide us. We talk strategy. We talk about what they see emerging. I'm talking with the ANA this afternoon, talking about how they see the role of AI affecting nursing as a profession and their work. And so they're just sort of, there's times where we get together and, we'll co-present on things or we'll help develop programs, but they're very involved, very supportive of the work that we do.
So many questions, Sean.
Okay.
I've just realized this is going to be a struggle for me. There's just too much to pick at here, but I'll do my best.
Okay.
All right. So start with size of the organization. So how do you define the size of URAC?
Well, it's actually very interesting because when I came to URAC, one of the things that I did is I spoke with a lot of people and I said, how big do you think URAC is? Because of our impact that we have as an organization, we were very fortunate. We were just named Best in Business in Accreditation by Modern Healthcare again for the second year in a row. We were the only accreditor named as a Best in Business. And so
That's awesome. Well done.
fantastic. Absolutely. So I ask people, I say, how big do you think URAC is? And a lot of the answers I get is I figure you're like, 300, 400 people located in Washington,
I
D.C.
think I think it's a trick question.
It is a trick
I'll tell
question.
you why. I think you've got a W-2 core contingency,
Okay.
executives, admin, corporate,
Hmm.
strategy, very seasoned experience because you've got to manage some really important relationships that have huge impact on everything that moves in healthcare. And then you've got this 1099 workforce I'm guessing, I have no idea. This is not chat GPT of accreditors who are out there, examiners who are out there in the field providing accreditation or not. And I think that 1099 workforce is probably measured in thousands.
So,
And the corporate is probably measured in tens and hundreds.
so let me tell you something unique about us. We actually employ our reviewers.
Wow. All right. So now that takes me in a different direction. So now I think you probably employ several thousand
So,
because you're accrediting all the time everywhere.
yeah. So we have a team of full-time reviewers, and it's a fantastic couple teams that do that work, and we do that for a couple reasons. One of the things that always frustrated me when I'd go through accreditations back when I was working with hospital systems and that work was you always felt like you got a reviewer who was in a bad mood. Or who didn't do many of them. It was sort of like, great, we got somebody who was grumpy the day that they were
Very hit and miss, my personal experience.
right.
John was excellent and Bob was dreadful.
So we actually employ our reviewers full time. And there's a couple reasons for that. Number one is we actually can do inter-rater reliability testing on our reviewers. So we actually check to make sure that it's not the person's mood that affects the outcome of your accreditation.
Okay, so quality control is critical for URAC.
Quality control. If you get the person who does maybe 2 or 3 reviews a year, number 1, they're not consistent, they're not experts at what they do, and number 2, they can't be analyzed for inter-rater reliability, and the other thing is that they can't bring best practices from other organizations. If you think about it, when your reviewer is dealing with your organization, they should be bringing something to the table also. And so what we say is your reviewer, when they come in and they work with you, first of all, you have a dedicated reviewer through your whole process. So it's not like you got a bunch of little staff underlings and then we hand you to the expert and then they disappear. They work with you throughout the process. But we actually have people with clinical expertise who come into your organization who've maybe seen 20 other pharmacies this year, specialty pharmacies or something.
Wonderful point. They have a lot to contribute,
They actually bring something to the table beyond our standards.
especially since the reviews are recurring, right?
Yeah. Every 3 years, our reviews basically are every 3 years. Although when you're accredited, you also sign up for, you could have a midterm review. We actually do a randomization to do a random check on some of the organizations. I used to deal, when I was dealing with accreditors, I used to say I always felt like their job was to catch us doing something wrong.
Yeah,
A lot of
there is plenty of that. The school culture. Go
uh,
stand in the corner.
get slapped on the wrist. But what I say is, I actually want our reviewers not to catch you doing something wrong, but to make sure you're doing it right even when we're not around. And
Very
so
helpful.
I'm going to circle back to your original question because I never have given you a straight
Yeah.
up.
So what's the FTE count?
It's 65 people.
How does 65 people perform the number of reviews that you're performing throughout the country?
We accredit over 1,000 organizations.
Yeah.
And so some of our
But that's
reviews,
assuming 300 every year, 330 to be
yeah,
precise. Yeah.
yeah.
Okay.
And so
That's
for,
a review. That's a review per day, per calendar day.
well, actually, what it comes down to
It's
is,
got to be more than that on a work day, right? Because you're squeezing that into work days. So it's got to be at least a couple of reviews per day.
so kind of. Let me explain that. Our reviewers are working on a batch of reviews at any one time. Their on-site reviews are done around 1 or 2 a week, where they're actually on-site with somebody. And now they can also do some reviews. Some of our reviews across our 40 programs are virtual reviews. So
Right. So you've got the in-person on-site. So
yeah,
that's 2 or 3 days.
yeah,
So
and then
that increases your frequency to 3, 4, 5 reviews per day because they're ongoing. And then you've got the continuous work that predates the review and postdates the review.
yeah, we
So
actually
now
did.
you need to handle at least. So you really don't have capacity for. Well, it's not a question of capacity. You're getting through 350 reviews per year. But I'm just okay. So 300. How many people do you have in your review team?
I think we're around 30. Just sort of off the top of my head, I think we're around 30 people who are doing the
30
actual
people.
reviews.
Okay. So 30 people covering 300 plus reviews. So each of them doing at least 10 reviews per year, right? Gets you
It's
there.
more than that, but yeah, I mean, now the thing is not every review is the same. I mean, if you're reviewing, Tom's local drugstore down on the corner, or if you're reviewing Walgreens, those are very different. And so for large organizations, we have some sampling about the number of sites that we visit and those sort of things. Some of our big reviews, we have a couple reviewers on a review to where they're all involved and they're doing that sort of stuff. So that's sort of the nuts and bolts of this. But very typically, people will estimate us to be, 400 or 500 people in URAC, and we're actually a
I
small.
estimated over 1,000. So I
Yeah,
was wildly off.
and so
So what are they doing when they're not reviewing a review per month?
so they,
What are
they
how are they
they
spending their time otherwise?
well, they always have responsibilities. Okay, so I mean, one of the things that we talk about is, how many reviews are you
You know
working
what
on?
I did get right that the corporate, the remaining 35 people or
Yeah,
30 people
yeah.
is
I mean,
quite tight.
we've
That's
got
tight.
an IT department. We've got. I mean, we're not bloated by any measure in this organization. Let's be clear about that. I mean, I've got an IT department. I've got media and marketing and communications. I've got government relations.
And I got right that every one of those departments is led by someone very senior and experienced. It's a
Yep.
core team of experts.
Yeah.
Okay. So I'd give myself a C, a solid
Okay.
C.
Well, I think it's important that the things that differentiate us as an organization are some of the key things there. I mean, if we were picking the reviewer of the week out of a hat who does maybe 2 of them a year, we'd have to have a whole bunch of people on a leash for doing that sort of work. But because we have our own teams, One of the things that we value incredibly and which we think contributes to our best in business recognition is the idea of avoiding conflicts of interest and high integrity. So, for example, when we do a review for an organization, our reviewer will work with them and go through the entire process, score them, all that sort of stuff. Then all of that information then goes to an independent accreditation committee. And that's actually made up of people from across the industry, not employees of us, but we take all that information, all that scoring, all those sort of things, and we anonymize the application. So we actually strip everything off of your application, and when it goes for approval or denial, that identifies the organization, because we say we don't want your reputation to help you or to hurt you. I think we've all seen sort of places that get by on their name brand has been a concern, and so we avoid that. So when our accreditation committee is voting on an accreditation, they're not voting on Walgreens or Blue Cross Blue Shield. They're voting on application 0793. And we say we want to avoid conflicts of interest. We don't want people to think you can buy your accreditation, and we don't want people to think that your name helps you or hurts you. The certificate that I sign for every organization, and I hand sign those, there's no auto pen going on here in DC, is actually, to me, that's like signing a prescription. That's me putting my name down as being,
Yeah.
we looked into this organization, and for older people, it's the good housekeeping seal of approval. So that's why I hand
Well
sign
said.
every single one of those.
It's a real responsibility. You don't take it lightly. Why would I pick URAC versus Joint Commission? You mentioned that Joint Commission does a lot more hospital work, but what's leading me to URAC versus Joint Commission or AAA?
Well, I would say that, first of all, the organizations that have worked with us feel that our accreditation is more collaborative. It's not sort of a catching you doing something wrong, it's helping you to do it better. It's bringing those best standards in. A lot of people who work with the Joint Commission work with the Joint Commission because it's required to get paid by Medicare. Um,
Right. So I was going to get to that topic in a second. Okay, keep going. That's an important one for me.
and
The requirement part. I want to
yeah,
really unpack that.
Yeah, so very few of our accreditations are required. They are all generally the people who go through our accreditations, the organizations that go through our accreditations, are because they want to say, we went out to independent experts who looked at what we are doing, and in this case, an organization that's best in business already themselves. And they came in and they looked at our processes, they looked at our people, they looked at our credentials, qualifications, practices, and they also brought in best practices from across the country from other organizations that have done this, and they helped us to be better.
So let me try and understand that a little bit better. So I'm a large orthopedic group. I employ 200 orthopedic surgeons. I'm
Yes.
in 5 different states. I have 60 locations, combination of practices and surgery centers. I have 20 plus different commercial payers that represent the majority of my revenues. 5 of which represent 80% of my revenues, my commercial revenues. I have a lot of Medicare. I have some Medicaid. And I look at my team and I say, who's accrediting us? And they say, Joint Commission.
Uh-huh.
And I say, well, what about URAC? And their response will be, well, the payers only recognize Joint Commission. What are you even talking about? What a silly question, Roy. Or, yeah, the payers require me to be accredited. And whether we're talking about Medicare or Cigna or Blue Cross Blue Shield,
Yep.
URAC is just as good. Just walk
Yeah.
me through that.
So the thing is we don't offer programs for everything. So if I were a group and I were saying, what could URAC do for me? We've launched the first artificial intelligence in healthcare accreditation. We have a large telehealth accreditation for best practices around telehealth. And there's a lot of talk on Capitol Hill about, how do we tell the good players from the bad players when it comes to telehealth or artificial intelligence usage, those sort of things. Credentials verification,
Yeah. I
those sort of.
want I want to attach all those programs to 2 buckets. Bucket A, required.
Uh-huh.
Bucket B, elective. So for me, elective, class and black book
Uh-huh.
in the world of revenue cycle management is elective. No one has to be class accredited.
Uh-huh.
They choose to be.
Yes.
But being accredited for a surgery center, that's not a choice. If you're not accredited, you can forget about your revenue stream, right? Medicare, Medicaid, and all the commercial payers, they're all gone. You can rely on patient paying out of pocket, which is not going to keep your surgery center open.
Yep.
So just
So
walk me through on the required side.
okay.
How do you stack up with Joint Commission when it comes to those revenue streams?
So just to use your example, so a surgery center. We do not accredit a surgery center. Okay. So there are requirements for accreditation. Generally, they're facility-based requirements. I would say the Joint Commission is generally a facility-based. That's what they started out as being, was sort of a let's check out the facility, get all the
Yeah.
boxes off of the top.
AAA as well, right?
Yeah.
They do it too.
Um, and so when we look at what we started with utilization review. So generally what you're going to see is we're not going to do a facility accreditation. We're going to do a quality oversight accreditation. Let me explain what I'm. So when we talk about, let's say our AI accreditation, let's pick something that's a hot topic right now. I say we don't accredit the algorithms. We accredit the oversight of the program. So we look at clinical oversight, ethical oversight, technical oversight, risk assessment of your AI tools. What is your monitoring program? Those types of things. We don't go, what's the third comma in the 37th line of code or anything like that. Because to me, as a physician who practiced for a couple decades, the scalpel is really important, but the surgery is a lot more than the scalpel. So we're not, when we go in, generally when we do an accreditation, we're not checking your fire extinguishers. We're checking your quality control, your quality oversight, your credentials verification, primary source verification, those
Understood,
things.
but I'm still at the beginning of my calendar year. I want to turn to my team and make sure that everything that I need to be accredited for in order for my claims to be honored by the government and by commercial payers is being handled. That's
Okay.
required accreditation.
Yes.
So where do you fit into that ecosystem, if anywhere?
Okay. So there's very few places where we fit into that. If you talk about a surgery center or something like that, generally, if you're running a facility, there's going to be requirements from your payers about
Mhm.
your credentials verification.
Yep.
Okay. That's some place where we would handle that accreditation for credentials verification within your organization. So that's one place where it could be required by your payers or by the government or those sort of things. There's not a lot of those. A lot of ours are about organizations who want to distinguish themselves as a market differentiator,
Got
not
it.
necessarily have to have.
Okay, so that brings me closer, actually further from the world of Joint Commission, which I always associate with required, right? And AAA. Without it, I'm not getting paid
Yep.
as a clinical group.
Yep.
And puts you more in the camp of class and black book. So class is not required. It's elective. It's a differentiating strategy. Look at me. I am scoring well on class. It's
Yes.
almost like a marketing strategy.
Yeah.
It has a lot of weight to it. They take their reviews very seriously. So it's important, it's effective, it's also a learning experience,
Yes.
but it doesn't binarily differentiate between revenue streams, right?
Correct.
You're
Yeah.
not either A, getting paid, or B, not getting. You might get more revenues because you're more credible, but it's not like it's existential. So it sounds like URAC falls more in that category. This is a way to differentiate certain programs that you're focused on. And so okay, so with that, and thank you for explaining it. Let's talk about a couple of your programs, which I find particularly interesting. So you mentioned, I'm going to circle back to AI, but let's focus on telehealth for a second.
Okay.
So you mentioned overseas telehealth, and I have struggled with overseas telehealth for a while because there appears to be a massive roadblock here in the US, a binary roadblock in that Medicare won't allow it.
Yes.
No payments for overseas clinical work whatsoever,
Yes.
which seems highly inflationary. We will not import healthcare, is what Medicare has said. We will import shoes, we'll import computers, we'll import other services, but when it comes to healthcare, I don't care how good those doctors are in Spain, they won't touch a single patient, a Medicare patient, which I
Yes.
think is insane when you think about it. Because the right question is, here are the standards which Spanish doctors need to meet in order for us to honor their work. If you meet them, great. If you don't, then you don't. But they haven't said that. They've said, we don't care how good, available, low cost, reliable this care anywhere in the world might be, no matter where it is, no matter who it is, we won't honor it. So am I wrong in understanding that? And I might be, because URAC is accrediting overseas telehealth groups. So what am I missing? Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield proactively prevents denials before claims ever go out, using agentic AI to automate root cause detection and resolution. Front Desk Shield streamlines preclinical and front-end workflows, eligibility, authorization, and intake, reducing friction before revenue is even created. And Revenue Shield maximizes charge capture and revenue integrity, ensuring nothing slips through the cracks. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scalehealthcare.com and see how the Shield suite is redefining AI-powered RCM.
So you're not wrong. And let me just circle to a thing related to that. One of the reasons why I took this position in Washington, D.C. is because I was very frustrated. I've been part of large hospital systems. I've been part of ACOs and those sort of things. Is I found it to be very frustrating that organizations would be doing something that I felt was really in the patient's best interests. And then, as I used to say, some silly person in Washington, D.C. would move a comma or change a phrase within a law, and all of a sudden it would break.
It's illegal. It's gone.
It's all of a sudden it's. And so I mentioned earlier, I said I'm going to be over on Capitol Hill this week because I'm going to be talking with people about artificial intelligence in healthcare. Because honestly, a lot of the people who are making the rules around what's legal and what's allowed don't know what really happens. And I believe that having a chance to influence these things while they're still in pencil before they're written in pen or signed off on has a chance to shape these in better ways. And so that's one of the reasons why URAC is involved over on Capitol Hill, why we do this work, why I fly to states, why I testify, those sort of things. Circling back to the particular case that you said, we were doing telehealth accreditation back before the pandemic, okay, because we think that telehealth is a good thing. It's an extension, it improves access, those sort of things. We were strictly doing US-based telehealth. And then the pandemic hits, and all of a sudden there's this huge rush into telehealth. And so the pandemic hits, and all of a sudden there's this huge rush into telehealth, and these valuations go through the roof on these companies and these sort of things. And honestly, one of the biggest concerns that the government had was, how can you tell good telehealth from bad telehealth? Okay. It used to be that if you went to the doctor's office and you saw a doctor's office and it was in a pretty nasty building and you went inside, there were cockroaches and the ceiling tiles were falling down, you'd go, I'm not sure I trust this place. But quite honestly, in telehealth, if I got a good background and I look like a nice person, I'm a doctor, congratulate. And there's no verification of that. You couldn't tell the good guys from bad guys. And so we had an organization come to us and they said, we want to buy your accreditation. And I said, well, you can't buy our accreditation. You can apply for our accreditation. And they were sort of stunned by that because they're sitting on this pile of money and they want to have somebody say that they're good. And I said, well, what's involved is we actually have standards that we publish. They're available on the web that talk about what is good quality telehealth. And you can go through the application process. And they said, well, tell us about your standards. And I said, well, it's things like, are your people credentialed? Are they covering things appropriately? Are they using prescriptions appropriately? Those sort of things. Are you following HIPAA? And they said, what's HIPAA? And I said, what's HIPAA? I said, let me save you some money. Don't apply for our accreditation. If you don't know what HIPAA is, you shouldn't be doing telehealth. And so our telehealth, we had this surge of organizations who came in who earned our telehealth accreditation, good quality organizations. And we were actually approached by somebody from the Middle East. And they said, when we look around at places around the world who are doing telehealth accreditation, your program stands out. Would you consider accrediting us? And it was an organization, Ann Shams University in Cairo, Egypt, that was setting up telestroke coverage. And they said, we wanted to follow your best practices. So we were not doing international telehealth before the pandemic until we were approached by organizations who said, we want to do your standards. And they were our first international accreditation. Now,
they approach you, they get the accreditation. It doesn't help them in the US. It helps them in other countries.
It helps them in other countries.
Got it. So other countries, and I've seen this, are busy importing healthcare.
Yes.
We're not.
Yes.
So I'm gonna leave a long pause for theatrical effect, so our listeners can process that.
Well, I think, let's be clear. We don't even allow things to happen nationally when it comes to healthcare. Every state controls their own.
These are straight restrictions and state frictions. Yes, yeah. For sure. I've heard those complaints as well. So it is just amazing to reconcile that with complaints about cost of healthcare, because they don't reconcile.
Right. But whenever it comes to sort of that debate, it's cost versus quality. And someone who says no, we have to have tight control as to who provides care. It's always they always state it from a quality standpoint. Now let me tell you, I practiced in Missouri for a decade when I first came out of
But
residency.
but that doesn't stand up to argument. That's just a heading. It doesn't explain the inefficiencies in our academic system and insanely tight restriction on residency programs across the country. It doesn't explain, and not just residency, but all training of all clinicians, including nurses as well. Just absolute tightness on the amount of graduates on an annual basis. And it doesn't explain, zero telehealth from overseas, zero. It's a false argument.
Well, no.
It's just rigidity for the sake of rigidity. We used
No,
to
no.
do it when healthcare was 5% of GDP. Therefore, we still do it today.
It's not a false argument. You can't dismiss it that completely. Let's be clear.
It's not an argument that other countries are suffering from. Are they not interested in quality?
Well, now we've wandered into residency slots and control of licensing and those sort of things a little bit back from our base of accreditation. I'm happy to go there. So, for example, there are different training requirements in different countries around the world.
For sure.
Okay. There are programs that would like to come to the US who would not meet US quality standards.
For sure.
And how do you vet those? Now, the other end of the spectrum, there are some of the best healthcare delivery systems in the world located in other countries that we should be thrilled to let in the door. But
100%.
how do you decide?
And the ones in
door?
the middle who Shawn believed that they could ultimately enter, you would be the first person they'd call to say, help us get to the standards. Right? But they don't make the phone call because no one's entering. So that's my point. That's why I call it insane and indefensible.
And if you look at recent legislation, many states have opened up what has been incredibly walled off in past years. So there is an opening. If you look at training slots, if you look at accepting foreign trained providers, there
Right.
have been
That we do. We import them in individually, one at a time, as one clinician at a time. And we showed stats on this recently. There are certain countries, whether it's Sweden or the UK, where 30, 40, 50% of the clinical workforce is foreign imported because their homegrown academics and their ability to incentivize homegrown citizens to sign up for those programs is heavily flawed, right? Which also speaks to their income programs, right? Their wages and how they go about funding healthcare. So they have another problem. They've solved for it. Whether it's a net positive, doesn't matter. Necessity breeds invention. So that's the solution. Import clinicians. Okay. But then and I'm stubborn about this point. I'm not stubborn about everything, but the few things that I just don't understand, no matter how many times someone's trying to explain it away, I've grown quite stubborn about it. The fact that we don't allow a single foreign healthcare clinical group to supply 350 million US patients with any healthcare is indefensible.
Okay. Yeah, you're stubborn about this. I completely agree with you. I will also say that there are concerns that are valid about what are the appropriate gates that someone has to pass through to come in and to deliver care.
Same gates as we create for all US healthcare providers. Those gates exist.
They do.
And, we could make the argument that sending a URAC team on a plane to somewhere that's 10,000 miles away as opposed to somewhere that's 5,000 miles away is logistically much harder. Time zones, culture, language, harder to verify. But in this modern age where we live in a global economy, okay, from one year to the next, from one administration to the next, the definition of global changes. But so much has been achieved globally. By comparison, here we've achieved zero. That's the part that I really struggle with. You could argue, Roy, we're just not moving at the same pace as other industries. And I would be supporting that all the way. We shouldn't. We should be more careful, more risk averse. The gates should be very strict and unforgiving. Absolutely. All of that, you've got my full vote of support. But the fact that we just have zero, turned it off, is the part that I just don't understand it. I don't. While we're spending 17.6% of our GDP on healthcare and seeing still 10% inflation per year in hospital care.
Somebody, if a foreign organization wanted to come to the US and they wanted to open a hospital, there's a path for doing that.
Yeah, become a US entity, sure.
Yes.
But there are means to supply telehealth, which doesn't require any of that. And that's not available. And now we talk about other forms of accreditation that you're involved in as well that I think travel,
Mhm.
right?
Yeah.
And they travel well. So let's talk about AI.
Okay.
Okay, so you're now accrediting AI. What is accrediting AI? You mentioned you're not focused on the code itself, but you are focused on compliance. Which AI companies providing what solutions fit your jurisdiction, fit your ecosystem?
So let me give you an origin story for this. So I was a chief medical information officer for a couple decades.
By the way, I can see how you're much better suited to live in DC and deal with our regulators than I am. I need to stay in New York. There's a certain diplomacy gene that I was just never granted or gifted. So my respect and admiration to you and your ability to navigate these topics. Let's keep going. AI.
So for AI, I was a chief medical information officer. So I have a couple decades of experience of putting technology into healthcare settings, be it clinical, be it hospital, all these different locations. And so I actually spoke on AI in healthcare back in 2018. So coming up on 7-8 years ago, I actually spoke to a bunch of chief medical information officers about the promise that AI held for healthcare. And it's sort of been out there for a while, and we've seen this boom over the last few years. And quite honestly, the last administration had some pretty strict sort of guidance that they were putting around AI and AI in healthcare in particular. And when the new administration came in, they basically threw out some of the executive orders and those sort of things. And that's when we started developing our program. So we started developing our program last year, early on in the year, and we felt there was a need for protecting patients and providers for using AI tools. There's probably 40 different organizations that have put out some sort of best practice guidelines or those sort of things, governance guidelines for AI in healthcare. And we said, we really think that this would fit an accreditation. What's the quality oversight for this? So we put out a public call for advisors to come in and serve on an advisory committee for us to construct a program. And the idea at the time was that we are going to write a program for users of AI in healthcare. And we got this group together. We had over 70 different applicants to serve on our advisory group. We ended up with 29 organizations, everything from lawyers to academic medical centers to frontline providers to ethicists to developers to all these groups. And we got them together and we said, we want to build a program for users of AI in healthcare. And they said, absolutely, you need to do that. This is coming in. It's coming in so fast. There's all these different sort of, an organization will build their own AI tool and roll it out. And what's the oversight and those sort of things. But we also need one for the developers because they were very concerned that their providers were going to a trade show and seeing a shiny booth selling some sort of AI tool, coming back and saying, hey, we need to do this. And they couldn't tell from a shiny booth whether it was actually a good tool or not. And so we actually, instead of just developing one program for the users of AI, we developed one for the users and one for the developers. Now, the developer one takes a look at things like data governance, appropriate oversight of the whole development process, contracting, liability, business continuity plans, those sort of things. And then the user side looks at things like training, risk assessment, oversight, monitoring plans, public reporting, informed consent, all those sort of things. So we actually have two programs, one for the developers of AI in healthcare, one for the users of AI in healthcare. And we launched it on September 15th. We were the first organization to put out a program like this. And we've had very good response. I think we're up to around 10 organizations right now that have already signed up for the accreditation process and are going through it. Some that are users, some that are developers, some that are both. And we've had very strong interest in this program. Again, it's not required anywhere. So this is organizations who are wanting to sort of not just say they're following best practices, but actually prove that they're following best practices from an organization that's been looking at healthcare and quality for 35 years and providing that external oversight.
So let me try to understand it a little bit better. It sounds to me like a wonderful place for you to reside when it comes to provider interfacing AI. Hey, I'm now going to influence how my physician performs, treats their given patients or given patient on any given day,
Yes.
whether it's through scribe, co-piloting, right? Or whether it's through treatment, co-piloting, absolutely, or whether also similarly, definitely patient interfacing AI, whether it's through chat or whether it's digital portals that patient engage in discussion, right? Chat bots, anything that influences the experience of that patient. Interestingly, I don't see Chat GPT signing up for URAC accreditation. I haven't seen it, and yet I think they're delivering healthcare. It was only this morning that ChatGPT was advising me on my waist size. I asked the question, but so it's very real time ChatGPT in healthcare, and yet there's no accreditation. So I can certainly imagine how that extra layer of compliance quality is critical. But I also see a lot of other AI, and I'll double back to that in a second with the same question. I see a lot of AI tools that are not provider interfacing, that are not patient interfacing, but might be focused on the systems and the plumbing. Revenue cycle management is a perfect example. Maybe payer interfacing, but there you're dealing with SOC 1, SOC 2, you're dealing with HIPAA, right? You're dealing with standard infrastructure that speaks to compliance and security, contingency plans, and so forth. And so I don't know that those back office groups that have nothing to do with patients need to race to get URAC accredited anytime soon. So is that a fair description of where the focus needs to be?
So yes and no. Let me clear that up a little bit. When it comes to AI in healthcare, there is the direct care affecting tools that AI is getting involved in. I always say if you're using AI because you want to determine the shopping list for the hospital cafeteria, we're not too worried about it. But if you want to use the AI to determine the chemotherapy for grandma, we think there needs to be some better oversight of it. And a lot of these tools that are coming in, you're right, there's a lot of back office tools that are coming in. And I always say that right now, denial management and prior authorization is sort of an arms race between provider AI tools and payer AI tools, and they're sort of racing up the chain on these sort of things. And you mentioned things like HIPAA and that sort of stuff.
Yeah, predictive analytics, cash flow forecasting, those AI tools, I don't think they're racing to get URAC
No,
accredited.
no, they're not, and that's not our main concern. What we do say is we want to provide a framework for an organization, especially healthcare organizations, about what they should be looking for when they are even assessing tools. That's sort of the developer framework. I was talking about this early on, and a person from a state hospital association said, "Oh my gosh, I would love it if we could ask every developer who wants to sell us an AI tool whether they're URAC accredited, if they're going to affect clinical care, because right now they can't tell the good guys from the bad guys." And what we're saying is this is about guardrails. This is not about closing roads or anything like that. This is about, what's a good quality framework from an organization who's been doing this for a while. But for AI tools that are starting to affect patient care, right now the biggest use of AI in healthcare is probably ambient scribes. Okay?
Yeah.
And if I were to tell you, you go to the doctor today and you're in your doctor's office and there's an ambient scribe, first of all, did they ask you if they could use it or not? Did they talk to you about your privacy expectations or your privacy protections? If you went to the doctor today and you had a rash on your foot and you talked to your doctor, I got this red spot on my foot, it's been itching a little bit, can you make any recommendations for me? And your doctor gives you some feedback and that sort of stuff, and you sort of go on with your day. If tomorrow morning you opened up your shopping tool on your phone and had a bunch of foot cream recommendations, you'd go, where'd that come from? Especially if it said, I know you were talking to your doctor about this yesterday. Perhaps I could recommend some foot creams. You'd be going, wait a minute, where is my data going? And quite honestly, today people are talking about stuff a lot more sensitive than a spot on their foot in their doctor's offices. And with all the privacy concerns that we have, different states have certain privacy protections, those sort of things.
You
Who
don't think that a typical HIPAA BAA agreement, and you don't think that the focus around PHI and the treatment of PHI, you don't think that is sufficient to restrict an AI company that's entered into those agreements from grabbing the data and then misusing it?
So let me put it this way. Number one, when these tools were rolled out, do you believe that every physician was told about the privacy protections within a new tool being rolled out?
No, no, I mean, I'm being devil's advocate. I
Yeah,
clearly see, as I said,
yeah.
leading up to this AI, I clearly see the need for URAC type accreditation in patient interfacing tools, AI tools. Clearly, I'm questioning
Yeah.
the free flow of data. I don't see it as free flowing as that, because I do think with PHI, HIPAA, and BAAs, there is a sensitivity around PHI.
Well, let me ask you this: if you're talking to a chatbot that's not a healthcare chatbot, do you assume those same protections?
No, if it's not healthcare, no, because the topic of HIPAA doesn't come up.
Right. We've already seen chatbots get involved in healthcare recommendations. I mean, what do you think, chatbot, I should be doing for my depression? Oh, let's keep
Yeah,
this
no,
between us.
for
And
sure. There's a hole there. There's
so,
definitely a hole
so
there. There's a bunch of holes.
there's a bunch of
I
holes.
accept that part. There's a
Yeah.
lack of training.
Yeah.
There's a lack of standardization. By the way, I think it's interesting that the inflection between chat call centers that are FTE, human labor driven, versus call centers that are increasingly AI driven, and where we will build a lot of compliance and accreditation for AI call center solutions, when we won't necessarily match that standard with human call center solutions, which is interesting.
Well, we actually accredit call centers. And so a few years ago, we actually started adding to our standards oversight for AI tools being used in call centers. So our accreditation for health call centers actually includes that type of oversight, whether it be for people or whether it be for AI tools. So now again, we also have tools that are honestly being developed within a healthcare institution and then being used in the same healthcare institution. If that were a drug that was going through that path, you'd have an institutional review board that would have to sign off on before that's ever being used on a patient. What are the ethical considerations? What are the data considerations? What are the clinical considerations? You've got a state now that has passed a law about allowing AI to do basically autonomous refills on some medications, some prescriptions. Our program right now, as it's written, says that a clinician has to have oversight for any activities that are being done, which are typically within a licensed provider, because we still have a model in the United States of where the liability goes with the licensure. I was over on Capitol Hill and I was talking about our program, and I said, our program doesn't just say that a clinician needs to bless it when it's implemented, but they have to have oversight for the clinical decision making. And I had a junior staffer in a congressional office say, no, we need to not put those kind of restrictions on AI. We need to let AI do whatever AI can do. And I said, where's the liability? And they said, well, what do you mean? And I said, well, if it's wrong, I mean, we have a model where if a human makes a mistake, we understand where the liability falls. What happens if a AI tool makes a mistake? And they're like, well, they're more accurate than people. I said, that's not the question. They're not 100% accurate. So what do we do with the mistakes? And also
This
drift and bias and hallucinations. We've seen all sorts of behaviors from AI tools that if a doctor did the same things, we'd be pulling their license.
this countervailing forces when something new shows up, unproven, fragile, young, lacking investment infrastructure, is true for all industries all the time.
Yep.
It's the mess, right? It's the mess in the kitchen. And I accept the junior staffer's point. I do, because as someone who develops new concepts regularly, it's part of my business model. When something is 5 seconds old, the last thing's like a baby. The last thing you want to do is give it a heavy backpack and say, now carry this. Right. And we both know that accreditation of any kind, if it's real, is formidable. It's expensive. It's a focus of time and resources. And you're busy building the infrastructure. And the challenge with technology and AI, no different, is that part of the build involves interaction. There's books written about Facebook and Zuckerberg and all the different changes that Facebook has made over the years, and many failed. But what constitutes failure? It's going to market with something that people hate. And that's very common for technology. You sort of need to see usage, pilots, and so forth. So even that is requires its own degree of oversight, right? So, okay, so we will allow innovation, but contained and controlled with reporting and with standards. And some can innovate, others shouldn't really have the opportunity to because they don't do it well. So the whole thing is interesting, shall we say. There are countervailing forces. But you do want to get to a point where you're as organized as possible, as quickly as possible, because at the end of the day, it shouldn't be lost on anyone. Risk in healthcare is not a great combo.
Yeah. The AI tools, one of the things that the AI developers will talk about is they're very concerned about states having different rules and different laws and those.
Yeah. Yeah.
They talk about the concern about a patchwork of
Although they should be used to that by now, because
right,
that's been the reality in US healthcare for a long time.
right. But the thing is okay, our AI program, and by the way, you talked about accreditation being expensive. What do you think the list price is for our AI accreditation?
In AI,
Uh-huh.
$25,000 to $45,000.
It's $28,000 for a 3-year accreditation. That I
3
mean,
years.
which I don't think is ridiculously expensive for. I mean, this is having a reviewer who knows your organization, who works you throughout the process and all this sort of stuff, and
You got
bringing.
to add to that the time commitment as well.
Absolutely,
Focus.
absolutely. Yeah. Um, but I think that sort of oversight, that seal of approval and those best practices. A lot of organizations say they follow best practices, but best practice saying you follow best practices is like saying you made a New Year's resolution.
Yeah, you know what's going to happen. The best operators will gravitate towards you and they'll go through the exercise and they'll get the rewards of representing that they're accredited by URAC. And then others will have no choice because the market will educate itself that it's important. And then we'll get organized that way. So I'm very optimistic for what you're doing there. And I know you've already done the same thing in all these other categories like telehealth, which is an area that clearly I'm very frustrated by. So I'm in general very grateful, Shawn, for what URAC represents. It helps all of us that there are organizing forces in healthcare that are very passionate about what they do. So very grateful for your time this morning. Very informative. Excited for our audience to listen to this and excited to work with you in any way that I can be helpful and Scale can be helpful over the years to come.
Well, for all of your listeners, I do want to say URAC, URAC.org is our website. All of our standards at a glance for every program that we offer is available on our website. So you can look at them for free to see sort of what we're looking at and those sort of things. If you want to actually see what our standards are, you can go through our website and purchase the standards to look at what we're actually looking at in detail for those sort of best practices. But I appreciate the opportunity to get together with you and to discuss the global economy of healthcare and the restrictions that the United States places, but also to talk about what we're doing and how we're trying to make it better.
Thank you, Shawn. I appreciate it.
Thanks.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.